So, happy noon hour, everyone. I'm Joe Zenel, interim chair of the Department of Pediatrics, and I welcome you to our grand rounds. Today's speaker is Dr. Sandra Peynado, clinical assistant professor in the Department of Psychiatry at the University of South Dakota Sanford School of Medicine. In 1998, Dr. Peynado received her medical degree at Metropolitan University at Barranquilla, Colombia. From 1998 to December 1998, Dr. Peynado served as the general practitioner at Hospital San Jeronimo, Monteria in rural Colombia. And from 1999 to 2000, she practiced in Cordoba, Colombia. In March of 2001, Dr. Peynado came to the United States, first working at the Presbyterian Healthcare in Charlotte, North Dakota, and then she came here to South Dakota to enter the adult psychiatry residency at USD SSOM, followed by the child and adolescent psychiatry fellowship also at USD, and she graduating in 2015. From November 2015 to April 2017, Dr. Peynado served as an outpatient, inpatient adult psychiatrist at the Veterans Health Affairs in Sioux Falls. And then in April of 2017, Dr. Peynado joined Sanford Health, and she now practices child and adolescent psychiatry at the Sanford Health Psychiatry and Psychology Clinic at 2400 West 49th Street. Dr. Peynado has published in the Journal of Academic Psychiatry on the subject of developing cultural competency in general psychiatry residents and has presented to our grand rounds in the past. So please welcome Dr. Peynado, who will discuss conduct disorder in children and adolescents. Thank you, Dr. Peynado, and welcome.
Well, thank you so much for the introduction and thank you for the invitation. I'm very pleased to be here and share with you information about conduct disorder. So let's talk about it. So one of the things that I would like to share with you is about conduct disorder criteria. Sometimes we want to make sure we identify appropriately our patients with this disorder. So if we have a kid with repetitive and persistent dysfunctional behavior, at least we want 3 or 15 criteria in the last 12 months. And at least one criteria needs to be present during the last 6 months. So time frame is very important when we gather in this information. Make sure that we are asking how long, how frequently, and try to identify a grade of severity. When we have families who come complaining about aggression, very important will be describe that. What do they mean with aggression? You can be surprised on how, depending on the family background, sometimes culture in that family, they can identify aggression in a totally different manner. So one of the most important ways to group these symptoms is identifying is any aggression to people and or animals. So aggression to people, that would be bullying. And then what kind of bullying? Is your child bullying other kids? Is a school calling you because your child has been involved in a situation that he has been verbally or physical or even emotional aggressive against another children or adolescent? Fights, any fights, is punching, kicking, hitting, scratching, using any weapon. And it could be from using a pencil or using a chair, a book, and the worst scenario, using a gun, using a knife to threat somebody else. Is the child or the adolescent displaying any cruelty, maybe squishing an animal, despite the animal is showing discomfort in their own way, and the kid keep squishing without any acknowledgement of the suffering of that animal or person. Confrontational stealing, cases when you have a kid who actually threats somebody else to take the lunch, to take the money, to take a toy, or in adolescent or in bigger groups, people or kids who are part of a gang, they get together or threat another person to take money or anything else with confronting the victim with a gun or with a knife or with any other potentially lethal weapon. And we also have forcing sexual acts. Are you having a kid, or is mom or dad complaining that this kid is abusing somebody else? It is hard when we are, as many of you probably pediatrician or primary care physician, these kids for a long time. And sometimes these are tough questions, but it needs to be really specific. We have young adolescents who may be forcing sexually acts in younger girls or boys. Unfortunately, it is happening, and they are threatening other kids. So it is tough to bring up these detailed questions, but that's the right to do, to identify the level of aggression and potential further violence against others. Other criteria: fire setting. Are we having a kid who is setting fires? And we got it also, again, when we ask this question, we can do it open questions, but also specify, was that an accident? Was that playful? Or is the kid enjoying setting fires? What have been the consequences of that settings? Is that something that you have to call the fire department, or is something that never happened again? You try to identify how severe it was, and if it's possible, describe that in your note. A lot of parents also complain the kids are destroying property, so make sure we are identifying what are they talking about. Are they talking about not being careful or caring enough with toys versus making holes on the wall or destroying other people's property, destroying furniture, or destroying other kids' property, or destroying a school property? So try to identify the level of the destruction. Broken into homes could happen more in adolescents, also young kids. Lies. You can be surprised how parents can describe lying. Got to make sure that the parent is not setting the kid to lie because of fear of being punished. What kind of lies and how frequently, to make sure it's appropriate identification. Stealing. Stealing is something that many families may report from some kids, and some families will tell me, oh, he's stealing food from the refrigerator, versus he's taking the credit card and buying things, or taking toys from friends, or taking tools at the school, books, pencils. That kind of differentiation is important to make difference between really stealing something in a legal and severe way. truancy related to missing school, not going to school. What is the kid doing when he's not at school? Is he staying at home, or is he going out there with friends or using any drugs? Are the kids following the rules or the time that they have to be at home? Are they following the regulations in the house or even by the state or the cities that indicate that they respect when they have to be at home? The conduct disorder, it is very important because this is one of those disorders that increase the risk of aggression, increase the risk of violence in our schools, violence in our homes. Identifying that in a young age could be very helpful, could help to prevent and be more proactive than reactive. And that's one of the major reasons why I wanted to visit with you about this topic, because that can help us to be more helpful to our young community and guide the resources appropriately from the society to our families, and be proactive. You as main providers, pediatricians, primary care physicians, a lot of times you are the ones who see people first line, and you can potentially impact the future of this disorder and the way how families interact and get services to help. So conduct disorder is more frequent in males, and some of that is just males. Sometimes they externalize more, or the aggression is more externalized and is more identifiable. Families notice it more. They are more disruptive in the schools and also in the homes. Well, we can have this disorder sometime even in 4 or 5 years old. Most of them will show physical aggression. It could be very severe and around 2.5%. Many of our kids who develop conduct disorder may have a history of ADHD, and even treating the ADHD, the conduct disorder, the aggression, the disruptive could still persist in a big percentage, even with a good treatment or even under multiple medications for ADHD. So very commonly, we also see an association with oppositional defiant disorder. So in the past, the DSM-4, before the DSM-4, we didn't diagnose together oppositional defiant disorder and conduct disorder, but it has been noticed that the differentiation was needed. So now we are able to diagnose oppositional defiant disorder and conduct disorder. It's just because the conduct disorder is in general significantly more severe and disruptive and could impact our communities significantly and the safety of people. So conduct disorder, we have adolescent onset and also an early onset. So it may be as early as 5 years old, but also as it could start more as a teenager. So the adolescent onset, we're talking about 13 years old, that usually is less aggressive than if it start early childhood, which sometimes make providers question it treatment, management when the kids are too young, but we need to remember data shows that the younger population, the behavior, the conduct disorder could be more severe than if it start later on as an adolescent. However, our society sometimes is more concerned about the adolescent behavior than the younger population. The adolescent onset is more adaptive, and that obviously is a strength and something that increase the opportunity to get better. So female and male radio is lower when it's an adolescent onset. That means it's very similar versus the early onset, male is usually higher in the younger population. So just to have a reflection about other things in our area of mental health, other comorbidities that increase the risk of aggression. So we have this autism spectrum. Autism spectrum kids have, or people have the decrease of empathy, difficulty with reciprocity, trouble with social cues. That definitely is going to increase the risk of acting out, being aggressive without any concern or without empathy about the victim of the other person. It's just part of the spectrum. Is harder for them to acknowledge what they are doing and the potential harm that they are causing to others. So why is it important to recognize that? Because if you have a kid with autism and you are starting early approach with social skills, you are going to have an impact in aggression. Disruptive mood dysregulation disorder is a disorder that in kids with ADHD, 75% of kids with ADHD will develop disruptive mood dysregulation disorder. Is part of a new diagnosis that has been noticeable. Is that combination between impulsive, trouble to regulate the emotions and in a reactive response to emotions that could potentially be very disruptive in a school. And obviously, it's going to cause significant aggression in different settings. Bipolar disorder is another comorbidity that is highly associated with aggression. Challenges treating conduct disorder. So a lot of times as providers, we also have difficulties to identify the patients and then what prevents us to act on this. But we also want to talk about the benefits of be proactive treating these kids who are struggling with this conduct disorder. So it's a stigma. Sometimes for parents, having this diagnosed, families having this diagnosed for your kid could make them concerned about the future, about legal consequences, and about how the kid is going to get better, how other people are going to see the kids. I have families very concerned about what are the teachers going to think about him or her, and how that's going to impact the future in school, the future sometimes in a career, military career, or in a police career, or as a teacher, or any other profession that a kid wants to follow. So the stigma is big, and we need to acknowledge it. We need to do open-ended questions for our families to see if that's part of the problem, and hopefully try to educate, provide psychoeducation, and encourage parents to seek further um, resources. So obviously the aggression um, is one of the main reasons why providers we act on this, trying to make the homes and our school more peaceful, and even impact the overall health of other kids. If you have a young kindergarten, first grade, who is extremely disruptive and aggressive, you're going to have 10, 15 other kids who are going to be exposed to this. It's going to disrupt their learning. So at the end, society in general and even other families can be affected. So in the future, we're going to talk a little bit about MTA study and what things have been helpful. So it's very important to offer complementary and alternative medication. Sometimes kids who have ADHD and on top of that have significant disruptive behavior, after a good evaluation and looking at the level of aggression and violence, it's okay to consider complementary and alternative medications on top of ADHD medicines. And also offer resources. Use your schools, IEP services, offer you other resources in the community, kids who can participate and organize sports or activities that teach some discipline, self-control, teaching to follow rules. Finding some mentors in the community can significantly impact these kids. So the benefits of you as a provider working with our mental health providers is that we're going to also decrease calls to police. Families are sometimes very disruptive that they require to call the police. Parents, mom and dad feel out of control, cannot keep this kid safe. They don't feel they can make them to calm down or be less aggressive. And a lot of times the police is called, which, sometimes is appropriate, and other times maybe could also put the situation worse and could escalate situations. So it's very relative. Some families are very comfortable calling the police, but in general, in my clinical experience, I see that things escalate, and unfortunately, maybe sending a message to the kids, that that it may be not always the most appropriate in a very young kid, but again, it's an option, but it could really sometimes be escalate the situation in some groups of families. So with you or with us working together treating the conduct disorder the best we can, we may potentially impact these things. We may impact psychiatric hospitalizations, less emergency services, and we all know how that impacts overall our society. Definitely, it's going to improve family relationships, decrease the risk of physical abuse. A kid who have conduct disorder, unfortunately, sometimes that could also increase physical abuse, and sometimes it's vice versa. Sometimes physical abuse also can definitely increase the risk of conduct disorder. So less risk of violence in a school, which is something that is sadly a major issue in our society. So we could indirectly help with that too. Less risk of youth detention centers and overall safer communities. So MTA is a study that was done for approximately 14 months. They evaluate patients, and 44% of those patients who have initial aggression remain aggressive. 26% of patients got MTA, and aggression is described as impulsive. That's so it's a study done for 14 months. Those patients who were part of this study have a lot of aggression, and that aggression was trying to focus in the impulsivity that those kids were having. So 40% of those patients, 44% of those patients have still some aggression and remain aggression, but a big percent got better. So here is a little more, a little graph that can help to explain that better. So methylphenidate, it was a study done for conduct disorder. Kids were treating with methylphenidate, which is a stimulant that is used for ADHD, but have also, in this case, they find out that also was very helpful with the behaviors. So they evaluate the situations with a scale called Aggression Iowa scale. They use that to measure the improvement, and they notice significant improvement with this medication to decrease the aggression, and kids were diagnosed with conduct disorder. Now we're going to continue talking more about treatment. We just talked about methylphenidate, which is a stimulant. Another medication that we have is clonidine. Clonidine, like you are probably aware of this medicine, is used for multiple things in our in medicine. One is for hypertension. Another is for sleep in some cases. And for pediatric patients, it's approved in the extended release form for ADHD. And some studies have also shown improvement in reduction of aggression, especially when added with methylphenidate. So clonidine is also called Capvey, which is an extended release, and that's the form approved for ADHD. And it has shown improvement for aggression and ADHD patients and with conduct disorder. So clonidine is a medication that works on the alpha-2 receptors. That's kind of the mechanism and the postsynaptic for ADHD and aggression. We're going to talk about guanfacine. Is also used for conduct and aggression. Guanfacine is also a medication that works in the postsynaptic alpha-2A. That's the way how it works for ADHD, and is more selective on the prefrontal cortex. It's a medication that also is used for many other things, ADHD. Also, it's a medication that is going to decrease blood pressure, so it needs close monitorization. It's limited data, but it's still some data that could be helpful. Every time we are treating ADHD the best we can, we have a potential of impacting our aggression and conduct behaviors. However, as we talk about it in the beginning, it could really, despite good treatment, those behaviors may persist. So there is a group of medication, kind of typical antipsychotics that we, sometimes we don't use it that frequently because of the risk for our young population. But overall, there are options that when things are very severe are okay to consider. And then you have a group here of very typical. So with these typical antipsychotics, we sometimes have a higher risk. Obviously, lithium is not one of them, but with this group of medications, a higher risk for abnormal movements, TD, dystonia, but still alternative and severe aggressive behaviors. So I just giving you some examples of double-blind research done for comparing molindone and tioridazine. You can see both medications were better than placebo, more sedation with the tioridazine group, but again, we see 25% of dystonia on molindone. There's an example of the doses that were used, and this was for a group of people, 31 patients between 6 and 11 years old. And the study was short, it was 8 weeks. It's another example of other alternatives of medication. Pilot-blinded study, chlorpromazine and lithium. A lot of times, most of the time, as psychiatrists, we are managing these patients, but just be aware these are options to help in severe aggression in kids with conduct disorder. This is an example with a very small group of patients, only 15. Obviously, it's hard to have big samples for these kind of studies because it's the population. But at the same time, as a study that was done in kids from 6 to 12 years old with conduct disorder, they were using doses 3 times a day. As an example with Haldol, the approximately doses that they use, 9.2 milligrams a day. And we also have lithium and with chlorpromazine approximately doses. So one thing is that in that small sample, a small group of people, the conclusion was that it did reduce the aggression in hospitalized children. Very important reason is aggression and out of control behavior. It is a reason to hospitalize, especially sometimes if there are no the proper resources in place, the supportive parents, sometimes overwhelmed parents who probably at the end of their road with trying to help their kids, sometimes because of the severe risk of this aggression is a reason to refer to hospitalization. This is another example of a study between lithium and haloperidol, double-blinded, 61 patients hospitalized, very young, with the diagnosis of conduct disorder. From that group, 4 were girls. You know, you can see some of the side effects with lithium and haloperidol. Drooling is just very common. The doses were 3 times a day, and this is very old a study. We're gonna talk about lithium. It's a medication that many of you acknowledge. It's a very good medication for multiple diagnoses and mental health, including depression, including bipolar disorder, mania, and also have some studies in kids that helps with aggression. Here you can just read a little bit about the side effects. Most providers are usually concerned about the kidney function, as long as you have a good candidate with good kidney function, hopefully good family environment, that somebody has, you want kids who have parents who are supportive and managing medication appropriately. Parents should be the one monitoring these medicines, not the kids. So most of the common side effects: nausea, vomiting, tremors, weight gain, stomach ache, headaches, diarrhea. I have a lot of patients no, that they don't always develop these side effects. It's all about going very low dose and monitor closely. Another option is Depakote. Many of you probably use for other conditions. Neurologists are using this one for seizures, but it's also a medication that could help with impulsivity and aggression and conduct disorder. We have a study in a group of kids from 6 years old to 13 years old, 27 children. The study was 8 weeks. The level of the Depakote that these kids have was an average between 80 and 110 milligrams per liter. And we have 57% responded well, so that would be around 60% improvement. Risperidone is, I noticed that is widely used by our group of clinicians, pediatricians, and primary care physicians. It has a good support that it helps with aggression. It has a good data that is very good for kids with autism who develop or show significant aggression. However, they also have side effects. The most common are weight gain, rarely, but sometimes also abnormal movements. So here you have the information about a study that was done with risperidone for aggressive behavior. Approximately 20 kids with diagnosis of conduct disorder. The kids were between 5 years old and 15 years old. They use a scale called CGI to monitor the level of aggression. And here you can have some information about how did it help. They have some exclusion criteria, which was kids who have a low IQ, or if the ADHD was extremely severe, or if they have urinary drug screening that were positive, they exclude those patients. It was mainly plain conduct disorder, try to minimize some of the severe comorbidities, and it was very helpful. So that study was for 6 weeks. The first 6 weeks, that was an open label, then it was single blind, and then after its maintenance of 6 months was double blind. So here we have another research about medications. This was one of the biggest sample research that have been done. TOSCA, treatment of severe children aggression. You can monitor and review it on your own, but it's one of the biggest research that we have. Very important, and it was in 168 kids from 6 to 12 years old. They review with a stimulant, with parent training, and they look and see how kids did with placebo. And overall, it shows significant improvement of patient management of this aggressive behavior with the stimulant. So here you can see adverse events more than 5%. Acute phase decrease significantly. Somnolence were some of the side effects, headaches, appetite, weight gain, abdominal pain. One of the side effects. Here we have the quetiapine also. It has been a medication that has been helpful for aggression. I won't go in details, but something to consider. It has, some studies have been done. Most of the mean dose to help aggression was over 150 milligrams. And one of the benefits of this medication is that it's sedative, and that sometimes is good as long as the kid is still functioning and doing well. And it was also adjuvant with the methylphenidate. It showed that was superior to placebo. And they also use the CGI, it's kind of called a cognitive global interview that kind of look how the kids function or respond to treatment. Abilify, very good medication, also used for aggression. The doses go between 2.5, 10 milligrams, 15 milligrams for helping with aggression. Olanzapine is also used. We sometimes have limitations with this medication. It's a lot of sedation, weight gain. Very important for olanzapine, risperidone, quetiapine. This group of medications require that we order glucose, lipid panel, make sure that we have a baseline and then monitor in 3 months, and then if needed farther than that. Of course, we have to monitor for abnormal movements, tardive dyskinesia, or any abnormal movements, changes on the sugar, as I said before, and sometimes require BMP. Measuring more the circumference around the abdominal area, kind of is a sign of obesity. And overall close follow-up for these medications, but it could be very helpful. Obviously, not everybody are good candidates for this medication, especially if you have a kid with severe obesity or severe or already have diabetes or a metabolic syndrome. Consider a different medication that is more weight neutral. Any questions? Can you hear me? Any questions?
Hi, I hope I'm coming through. This is Joe Zettel. Very good, Dr. Peynado. I have a question. So you have a patient that comes to you in the clinic and meets the criteria for a conduct disorder. Do you go straight to medication, and which one do you choose, or do you try behavioral intervention first?
Yeah, very good question. So definitely evaluate multiple things from the biological, psychological, and social aspect. So biological, you want to make sure sometimes identify what could be the cause of the behavior, which is very important. If it's something that is new, obviously may not be part of conduct disorder. It may be something new, or the aggression may be related to a physical symptom or a medical symptom. Sometimes in kids with autism, kids who have constipation. So at that point, you're not going to go directly to medication. Probably tries to solve the problem, what's causing the outburst. So find some comfort for that kid. I would say get good data, good clinic history, identify or try to identify the cause, the severity of the violence, of the aggression, and consider um, behavior management. I know we talk more about medications, but behavior therapy is very important too. In that case, if you identify that the kid just have something new, that this is not something ongoing, that he's not hurting somebody, or you not seeing that he could hurt somebody, a younger kid, or even the parents sometimes, um, that will help you to decide. Um, Conjunction with behavior therapy is effective. Like one of the things that I mentioned was parent training, but sometimes it's so severe that you have to intervene soon with the medication, understanding that the benefit may not be full. So definitely depends on the case, doctor. Depends on the case. If it's a kid with autism, you fix the constipation, the kid feels better, and you may not need medication. Important the follow-ups. That's the difference between an aggressive new outburst versus an ongoing conduct disorder that we're talking about 6 months, 12 months. At that point, you may need to intervene with a medication. Also, offering resources, like I said, resources like teacher training, IEP services, being able to give the kids some outlets at the school, a safe place to go when they feel overwhelmed or when things are difficult. Have a plan for that kid who is aggressive, so everybody is aware of it, and the kid and the parents are aware of it. Could have an individual behavior specialist who can also train the parent. That could be beneficial. And like I said, also the resources like involve this kid in routines with within the community, working with working with the police department with as a volunteer, or learning skills with a fire department. Um, Mentorships in the community are tremendously helpful. It's more like a multi-systemic approach. So usually in your case, I would say using social workers to specifically advocate for these patients and families to get some of those resources. But again, it's all about the level of how severe it is. There are things that need the combination.
Okay, thank you. There are some questions or comments in the chat,
Oh, I see.
which the first one being, do you think that anxiety may present as the MDD? Is the fight response or flight or fight their response to anxiety? Is the fight part of fight or flight?
Mm-hmm. Okay, yes, I see. That's a very good question. That would be, no, obviously, the anxiety area. People with conduct disorder can also have anxiety. If it's just the anxiety alone, yes, many kids who have anxiety, especially boys and the younger group, could have significant externalized behavior that could become aggression against others or even towards themselves. Again, you need to differentiate between conduct disorder, but anxiety can cause aggression. And identifying that and treating that with therapy if it's a young kid, or if you need a medication, if it's appropriate for that kid, like to treat the anxiety, that could significantly, I see it all the time. Kids get better from that point of view. if you treat the anxiety. But that would be if it's not really conduct disorder. If it's more anxiety, they could be aggressive. I hope that answered your question.
Okay. Several questions from Dr. Blake. One being,
Awesome.
which I would like to hear. How do you deal with a family of a child with the conduct disorder who have guns in the home, but the parents do not accept the diagnosis of conduct disorder?
Yeah, absolutely. That's a very good question. Okay, so you have a clear diagnosis, education. I do that every time. Just coming to see a psychiatrist is a stigma for many families. That's the reason why we in our system we have IHT or counselors that work at your clinics, because it can really can unify the acceptance of mental health easier with pediatricians. So education, psychoeducation. So I think it really helps when they hear about the prognosis, the benefits of treating it, versus only hearing the bad aspects of the condition. They are usually afraid of, the teachers are not going to want to work with my kid because sometimes they say my kid is a bad kid. It's difficult as a parent to have a kid who just don't follow the rules, don't follow the regulations. So I would say a lot of psychoeducation. I see that you put it on the Bridges program. They probably already getting some of that, but sometimes, a one-to-one visit with the parents, a lot of knowledge, a lot of validation to parenting. A lot of times parents feel guilty. There is a big component that we didn't talk about it today, but it's important when you educate parents, also the biological aspect that sometimes it's something that we don't always can change with good parent training and with good medications, even with good support. Like I said, it's a percentage of people who do not always get better. We just do the best we can in a systemic way, involving everybody in the community to really bring some understanding from parents. Education, offering support, offering connections with other families could be very helpful. We have the NAMI in South Dakota. They also offer family to family meetings. So sometimes when they don't feel alone, they feel the support, they move forward and hopefully get unstuck on that stigma. So a lot of education, support, sometimes even finding case management for that kid, parent training. It's just working together and try every time you interact with this family, try to bring some hope, because that's what they are losing sometimes. It's devastating for parents to have kids with aggressive behavior. It could be really affect parents. Any other question?
Well, I do not see any other questions coming, and I want to thank you, Dr. Peynado, for a great lecture and knowledge about the various medications. And I want to thank you and for your time.
Yeah. Well, thank you very much.
And have a great day. Thanks.